Thank you to our speakers. And now back to you, the audience, to engage in conversation with our speakers. For those of you who'd like to ask questions to any of our speakers, I'd like to ask you to come to the microphones and perhaps identify yourself. Let us know your name and perhaps where you're from, where you fit into our wonderful mesh of relationships, and we'll take it from here.
Okay. Hi, my name is Eamonn. I'm currently finishing my master's in medical illustration animation here at the University of Toronto. So if most of you are not aware, as a medical illustrator, we do provide visuals that you often see in medical textbooks, animations that you see in medical dramas. So we have a very unique skill set where we understand the science and we understand graphic design and the visuals. But oftentimes, I don't find us, kind of fitting in the realm of global health. And as a, global health enthusiast, I really wonder why. And I feel like there is a real need when it comes to this, where I think that we have the power to really effectively communicate a lot of the needs that most of you guys have been, mentioning in all three of your talks, and especially, the keywords I keep hearing in your talks is teaching and training. So my question is, as a medical illustrator and kind of as a aspiring future physician as well, what kind of role as a medical illustrator can we play? If we already play one, how can we play a greater role as a partner in health?
Well, I'll give you some advice, if I may, right? In avuncular style. If you're not in global health, you should get in global health, because for the reasons you just said so concisely. Concision's not really my strong suit. Just the training component. We do need help like that, and I say we, meaning the providers who span worlds. Again, it could be inside Toronto. Lucky team that gets to work with someone who can help communicate more effectively. And it's not just, it's not just for people who aren't literate or numerate. And there are a lot of people in that category but I think everybody needs to see something more clearly. And what happens, I think, is we get this kind of, well, it's just a hobby kind of approach, right? It's only global health. It's health for poor people. It doesn't matter. Get out of my way, sir. I'm kidding. I'm kidding. I would never say that. I would never say that. I'm just trying to make the polite Canadians, like, chest pain, falling over. Let's see how the family practitioners do CPR. Anyway, I really think, lucky team that gets to get that help, because we often have this, leftover skills kind of approach, but that's not global health equity. We want the best of the best. In Haiti, one of the things that's been exciting about this new infrastructure is when we launched the residency programs, and you heard this from Lynn and others, that teaching component needs to be formal. We had, for just 14 slots for the physicians, and that's not the only category of people trained, we had hundreds and hundreds of applications, the very best in the country, right? And that's what we want the best skills. The chief of medicine, a Haitian, returned from 20 years in New York because he finally had a place where he could practice. The chief of medicine, that same surgery was the first one. Chief of medicine came back from 15 years in France, and that's what we want. We want to draw the talent to the need, and I can guarantee you should have no trouble in a university. Imagine one department, hers, with 1,400 faculty. You think all those people know how to draw and communicate, and they don't.
But that's
so
the thing.
You gotta use tonight to. I'll personally say, here, look at this talented person. Also, she wants to be or thinking about being a doctor, or we'll take you with PIH Canada.
Ah, there you go.
Right, Mark? Thank you.
Thank you.
Hi,
I scared this guy now, and now he'll never trust me again.
My name is Luai. I'm a medical student. So I think the reason a lot of us are passionate about global health equities, we believe that the resources and the solutions out there, and the issues more with the distribution and delivering those resources. And I think at the root cause of that, a lot of it is a lack of compassion and understanding. So what advice do you have for us to kind of develop this compassion and persuade people who don't necessarily share that passion for global health, or that it's a priority, to convince them to take up this cause, and even at times when it might come at the sacrifice of themselves? So what advice do you have for us to do that?
Am I like the guru here?
Yeah.
You're on.
Well, let me just say this, because this is the
global health Oprah.
The surprising part, I think. I can say lots of things, and I would be glad to talk to you about ways of using suasion and opportunity and gentle nagging and other Canadian attributes to bring people on board. And I was saying earlier, if someone would have told me 10 years ago, Paul, one of the ways that you'll bring young Canadians on board is by working with a rock band like Arcade Fire. I said, really? Cool. So I think there are lots of ways that I would not have occurred to me, and we, would love you to be part of that. But here's one thing that I think is true after 30 years of doing this work, is that there are probably also structural ways to help people be compassionate. Now, others are going to dispute this, right? Compassion is something you have inside you, you evoke it. I'm telling you, good news, I don't believe that's true. I believe anybody can be pushed structurally into thinking compassionately. And setting up systems so people have a chance to be merciful, just, kind, compassionate, loving, all that is possible. You going to get my back on that? I use the L word, loving, right? And what does that mean? Well, if you set up a system where you have 100 people standing in line in the hot sun, and one doctor or one nurse, and everybody who's worked in, I'm sure, rural Ethiopia or rural Haiti or rural wherever has seen something bad like this, that is set up to just exclude any kind of compassion. So you start hammering on the clinicians, the doctors and nurses, social workers, by saying, here, do something that could not possibly permit you to cultivate compassion. That's the way to structurally determine that people be hardened, and you can think of a lot of words. So you actually need time, to be compassionate. You need to know that the recommendations that you give as a physician, because you're in medical school, they're going to be something that the patient can actually follow. That everything isn't stacked against that person. And even though Howard said, you don't have single-payer health plan, very professional, Dr. Who, Dean Who. So that is a structural intervention that makes it easier to be compassionate, right? But there are many, and I think that's what a lot of people don't have. Because after all these years, I think actually people are compassionate, and they have that in them, the ability to be merciful and just. We got to help them do it. You got to help them do it. And that's what Partners in Health exists to do, certainly. And I think that's what a really good curriculum in a medical school. Let the students have a chance to be compassionate.
I'm going to add to that just a tiny bit. My experience as a teacher of medicine has been that sometimes what we're really seeing in our colleagues that appears to be a lack of compassion is actually more fear, because they don't have the skills. So if our curricula don't address some of the more complicated areas of medicine, whether it be mental health, addictions is a perfect example, people will shy away and kind of put up a bit of a barrier. And I've seen student after student, when they really get the chance to learn about how to work with really very complex populations, that they just seem like completely different people. That was a big aha for me earlier on in my career.
Thank you.
Suzanne?
I'm Suzanne Jackson, an associate professor at the Dalhousie School of Public Health.
My question is for Paul, and I appreciate your work and appreciate your talk tonight.
But I was
very
warned.
Canadian. You're very Canadian warning.
I was warned.
You talk about one of the pillars of your ideal system has the community health workers as part of that system. And my own experience and observations is that that is something that is really needed when there's a lot of other things lacking. The problem or the danger that I'm raising, and in my question to you, is that that tends to put a lot of weight on a very vulnerable part of the population and actually perpetuates the inequity rather than moving that population forward and out of an inequitable situation. So I wanted to know about your comments about that.
Well, thank you for opening the door for me to say the following. The use of community health workers is not meant to occur only in places where there are not nurses and doctors. What we're arguing is that the working with community health workers offers the highest standard of care for chronic disease, not doctors and nurses. They can't do it without the community health workers. There's no setting, including the United States, where there are not community health workers, but there are, a city like Boston nurses, you have a patient with multiple diagnoses, HIV disease, say, major mental illness, addiction, and the doctors and nurses cannot provide the standard of care. They can only do it with again, this is a system, back to the previous question, that is structurally more compassionate. And so the only burden I can see being placed on people is not moving community health workers forward enough if their dreams maybe they want to be a nurse or a doctor, right? Usually in our experience with Partners in Health, I'd say 90% of the community health workers we work with have never had any job before, right? It's just that they live in areas with high unemployment in the formal sector, and this is their first shot. What I worry about is that we're not doing enough to say, okay, you know what, you're 40 years old now, you've been doing this for 10 years, what do you want to do? And that, I think, is a risk. And
right, and they're less compensated. For being such an important part of the system, they're actually very poorly compensated.
And let me just say this, guess what the argument is? The argument in the world today, just like, is it really a priority to build a teaching hospital after they've all been destroyed, which is idiocy in my view, as you can tell. The argument today is, should we pay them at all? Right. They're like, are you kidding? They're like, labor, payment. We pay, the very people who are making this argument, by the way.
They're doing it. They're making them.
That's right, they're making the argument, but they are handsomely compensated just like I am.
Right.
So that's what we have to fight. Again, like you were saying, let's get these people onto a professional development career like the ones we shower upon ourselves, or is that a mixed metaphor? And then let's make sure that we can fight for better working conditions for community health workers, proper wages, and proper training for all of them. So thank you.
Hi, I'm too small for this. So my name is Farine. I'm a third-year resident in public health and preventive medicine. And I guess my question, just generally speaking, is as an organization that is focused on health equity and social determinants of health specifically, because you are a health-based organization, can you speak to some of the challenges and some of the ways you've been able to leverage being part of the health sector in addressing or working with other sectors, so like working on or advocating for like healthier food or access to justice or the education sector, or just engaging in politics in general? And what would be some of the advice to some of us who are health professionals who are not always trained necessarily in avenues of like anthropology or politics or social sciences and things like that?
Thank you. That's a great question. I know Howard has some experience in this arena too. I would just say that this is, in my experience, that this is the toughest question we face in our work. Exactly that. It's related to the fear factor that you mentioned. Fear of not being able to, understand some clinical component. This is also fear of saying, oh my God, we just opened Pandora's box. We're coming in through this avenue of healthcare, but there's food insecurity, there's unemployment, there's this unfair trade. I mean, it goes on, and you know, climate change. And I think there's two bits of advice that I would share with anybody. One is that we need to understand as clinicians, and this is what you're doing your residency in, is they're fighting the social determinants of illness or addressing them. You know, you don't, the social determinants of illness as opposed to social determinants of health. We're supposed to be cheering on health. Is that right? You cheer on health and you don't like illness. Did I get that right?
I'm pretty sure.
Yeah.
Pretty sure.
Sorry. Social determinants, we got to figure that out as a profession or a set of professions, right? So should we all. Like how, you know, if poverty is the chief determinant, for example, of the persistence of an epidemic like tuberculosis, we better be thinking about poverty. But the remit of clinical work in general is health care. It's not that we're not paying attention to the social determinants. It's one of the big traps is people who do get overwhelmed by the enormity of the determinant problem stop thinking about how to deliver better health care, right? Equitable health care for poor people. And I would encourage us to be able to fluently make that distinction, right? And let me just put it in sort of grand, what you were calling anthropological terms, but I just think of them as, you know, sociological, meaning re-socialized terms. If you say, okay, gender inequality and racism lead to increased rates of HIV among poor women, right? I think that's true. I mean, clearly you all read my book, Women, Poverty, and AIDS, and you know the argument. The data seem pretty incontrovertible, right? But that doesn't mean we can say, therefore, we really don't worry about getting those social determinants out of the bodies of our patients who happen to be, for example, women of color, or whatever the term might be. That's our job too, right? Because we can also show that that's a risk for infection. Again, in this case, we're just using HIV. Choose a non-communicable disease. It's going to be the same, right? Chronic renal insufficiency. But it's our job to say we will also fight the manifestation of these inequalities in adverse outcomes for these diseases when we know that we have therapies that could make a difference. So that's a big confusion. Like, you know, the Luddite response is say, look, poverty causes TB, therefore we're going to focus on poverty and forget about actually diagnosis and curing TB. Big problem in public health, or big, you know, confusion. And then the other thing I'd say, again, that's a mouthful, right? It's not that easy to even say what I just said, that social determinants are one thing, and quality of care for people already marginalized by, you know, poverty, gender inequality, you go fill in the blank, is another complementary effort in the social justice struggle. Second thing I'll say is, you know, the secret is obviously partnership, as you already know. If you can find, if you're in a rural area like rural Haiti in the middle of a cholera epidemic, you can't really say, you know what, we don't do water, we do healthcare delivery. You can only say that if you find partners who will do the water, right? Or we don't do housing in the middle of an airborne disease. We don't do prison redesign of prisons. We just do healthcare. Well, you're in the middle of an epidemic of drug-resistant tuberculosis. You better figure out infection control pretty quickly. This is one of the things that you taught about as well. So I think partnerships are the only ethical way to offload these responsibilities. I don't want to learn how to think about food security, but I have to, you know, because I work with people who have it. I don't want to think about food deserts in Navajo Nation. Well, actually I do. I was trying to just be dramatic. But, you know, it's not like we have a choice, right? If we don't, and the only ethical way to do it is partnership, teamwork. It's a social justice, it's a movement. When we talk about movements, it's like it requires a big tent approach. And I like that part of the work, and I think you will too when you're done. You don't have any time when you're a resident, but you know, you'll like it. You like that. Building those partnerships is one of the most invigorating parts of this work. Thank you.
Thanks.
Love, Paul. Please move out of the way.
Thank you.
Hi, my name is Nikki. I'm a family medicine resident, PGY1 at St. Michael's Hospital. My question for you is, you gave the example of AIDS activist organizations as kind of being the impetus for imagining that treatment for poor and racialized communities was possible. And I'm assuming that you're referring to groups like ACT UP in the United States and Treatment Action Campaign in South Africa. And those were groups of people who were themselves directly affected, who then created a people's movement around access to treatment. So I'm wondering, as clinicians, we're often faced with kind of navigating a system and getting access for our patients rather than trying to upturn the system, trying to revolutionize things. And I'm wondering if you can talk about the role of clinicians and maybe academia in solidarity and also in people's movements.
Well, I mean, first of all, thank you for bringing that up because it allows me to say, if that was a question, was I referring to groups like ACT UP and Treatment Action Campaign? Yes, exactly. That's why I put their picture up too, as a tribute to activism. And all of us can be part of that. A second point is, there are limits, not to activism. I don't see the limits to activism. But if did you say you're a med student? Or are you a nurse?
Resident.
Oh, resident, sorry. So sorry. So, if you had said, I really, I can't understand someone with leukemia without having leukemia myself, that would be bad, right? We don't want that to be the projection of identity politics, is a danger in medicine, right? Because you have to be careful that, if I say, look, I don't have breast cancer, forget it. I can't understand. And I can't do anything. That's completely false, and it's recognized as such immediately, by clinicians, certainly by residents. So walking that line between survivorship, engagement, activism based on, one's own personal experience, one of the things that really I think is most impressive about ACT UP and Treatment Action Campaign is they were saying, hey, these people in Africa, in sub-Saharan Africa, some poor place, they're not really like me, but that's not why I'm doing this, because they're like me. I'm doing this because it's the right thing to fight for. And that, to me, is deeply moving. That's solidarity. That's universality. That's not a cheap projection of identity politics. And I know you're praising that as I am, and I just would warn, and you should warn your students against the idea that you can only understand something if you yourself have it. And because people come in when they're 22, 23, they come into medicine with ideas like that, and it's a hard lesson to learn. You learn it perhaps more quickly if you're, involved in global health in the sense of trans-local, trans-regional, trans-personal. And the other thing about institutions, and let's not get too staid, and not be willing to shake things up. I think the AIDS activists offer a good example, because they were saying, we want to shake things up so that the discovery process goes faster and better, so that the development process, the second D, goes faster and better, and so that the delivery process goes faster and better. And they may not have used those terms, but they weren't saying, let's tear down an institution that's worthless. They're saying, let's make it work, better for us. And, I think that's right. There are no doubt institutions that do need to be dismantled. But the pharmaceutical industry, the NIH, the public health, these are not the things that need to be dismantled. They need to be made better, just like public health does. And again, I don't want to sound like I'm giving a speech. I'm just, really pleased that you allowed me to make that tribute to ACT UP and Treatment Action Campaign, and to say that their tactics were very sophisticated, not crude. They were really focused on the outcome they wanted, which was health equity. And that was an important, it was difficult and painful in those early years, right, when it wasn't clear that it would pay off, meaning trying to make these institutions function better, but I think that was what they were aiming for. There's some historians of that era and those specific movements here at U of T, too.
Yep.
Thank you. Good luck in your residency.
Great. Hi, my name is Dr. Ben Chan. I'm an assistant professor in global health and in family and community medicine. It's a question for Dr. Farmer. Thanks for a great, inspiring talk. About a year and a half ago, I went on a volunteer mission in Haiti, and I read your book, Haiti After the Earthquake.
Okay, your $5 is, I paid him to say that. Thank you. Actually, it wasn't fun to write, so I appreciate it.
Yeah, and I went with a small NGO, and as you mentioned in your book, there's something like 4,000 small mom and pop NGOs on this tiny half island of Hispaniola. And obviously, that's a mind-boggling figure, and it must be an absolute nightmare, as you point out, for a government to try to make sense of everything that's happening within its country and to develop a unified strategy and plan. At the same time, there's an awful lot of entrepreneurialism, creativity, dedication, hard work, close linkages to individual communities that can bring in both people and funds to support the fight against the fight for global equity.
Yeah.
What's the way out? What's the solution to try to harness all of that collective energy in a way that doesn't make it dysfunctional for the host government?
Well, that is very poignantly stated, and as I said, concision is not my strong suit, so I'm just going to type that up the way you said it. Because that's right, it is a nightmare for the government or any other coordinating body, right? It's impossible. You have to say, okay, I hope that this will add up to more than the sum of its parts, again, or not, but I think the governments, by and large, do want to see development, progress, the fight for global justice. Or you have to say, okay, could we think of ways to maybe stratify the different NGOs and find out which of the larger ones could do more. By the way, I didn't mean to sound anti-NGO in that. I work with an NGO, and I teach at an NGO since Harvard, last I checked, is not the University of Massachusetts. And so I'm all for NGOs. The only question we're trying to ask is how can we add up to more than the sum of our parts? I think one of the ways, and again, nothing I'm going to say is particularly original. We definitely, I don't, and I don't think any critic wants to dampen that energy that you described, because that's critical to passion and engagement. I was joking with the students. Well, I wasn't joking. I was with the students today. I was telling them about the dangers of the QPE. They all looked like taking notes. I'm like, I just made that up. There isn't something called the QPE. The quest for personal efficacies. There's a danger to the quest for personal efficacy when you're talking about people's lives, but maybe it's worse. It could be worse not to have that quest for personal efficacy, right? That drive to succeed in what? Succeed in helping others. So, there are regional solutions, and I'll just say, because I could natter on as I did for 400 pages in that book. What we've been saying in Mirabalais is, come on, if you want to develop new businesses, like open beauty shops, great. We'll do the healthcare infrastructure. We need other NGOs to have a impact in this area to add up to the one. So that's a regional, like poles of development, partnerships, and I think there needs to be more of that in Haiti. And we have tried to yoke ourselves to a number of other NGOs in the regions we work. Not always successful, right? But I think it's been a good effort in that it's forced us to think really ever harder about partnership, not just with the public sector, which we've kind of mandated ourselves to do whenever we can, right, the Ministry of Health, but with other NGOs as well. A group of scores of them were meeting in Boston last week, foundations, small foundations, and some of their partners. We've done it in Montreal. We've done it in Montreal. We've done it in Haiti, and it's hard, but it's worth trying to do. It's not for every NGO. I get that. Sometimes they're very small, and their main partnership is that intimate connection with a village or a town. We can't be against that. We're not against it. Just saying, let's try to. The Rwanda example is very different, as I try to lay it out in the book, where the so-called NGOs that got kicked out of Rwanda, they were actually large. They weren't like small NGOs. They were big contractor NGOs, and how much they got kicked out, I'm not sure. I mean, what the Rwandan said is, look, here's our national plan, If you don't like it, there's a brand new road to the highway right there, to the airport right there. You'll love it. Now, as another friend of mine said, unfortunately, they all went to Burundi, meaning the NGOs. But that doesn't seem, that's not always a bad thing to say, hey, we kind of demand that we learn how to coordinate. The Haitians have not done that. They tried to coordinate the NGOs. They had 2 people tasked full-time in the Ministry of Planning, both killed in the earthquake. And so you got to have some sympathy, too, of saying we would love to allow them to do a better job, but not to make it some forced, artificial, we don't like NGOs. Nobody ever said that, not Partners in Health, an NGO, nor did the Haitian, government. So it's a dramatic question and one that I think we can answer just by, spending more time in partnership.
I am Carlos Montaner. I'm a researcher in social inequalities in health, and I teach here at the University of Toronto. And I'm Catalan. I'm from Barcelona, so I'm a little bit more cynical than the average Canadian. Although I'm trying to reduce that. So I appreciate your lecture. It's the best lecture I've seen for an MD on these topics. And if I had you as a teacher, I would have stayed in. I would have been a clinician, right? I'm sure I didn't have that chance. And I appreciate your books, the way you connect the individual with the historical and the macro, infections and inequalities. Even the first book on women and pathologies of power.
There's your reader.
Now I know. Now I know about that spike in sales in Toronto and Barcelona.
So my question is, maybe my premises are erroneous, but I've seen you associated with Bill Clinton, right? And I would like to know how you reconcile this contradiction, because here we're talking about somebody, without getting into the criticism of what the Clinton Foundation has, which is another issue. I mean, he really bombed Afghanistan, Sudan, Somalia, Iraq. His administration said that it was worthwhile to have 500,000 kids dying for some political goal. And also you have, of course, 2 cases that are very close to you. Rwanda, they looked the other way when it happened, and Haiti, where he supported the overthrow of Aristide, who's the first Aristide, who was more egalitarian. When he came back, he already was for privatization, and the Republic of NGOs, and fight among NGOs that you read.
I think you don't like Bill Clinton.
No, I mean, it's, yes, that's right. I don't like him, but it's more, you got me. It's more generic. I would have said the same about Bush, or maybe an European, well, Europe and the US are on the same boat.
NSA is just switching my bad.
So to finish, well, I suspected that. It's always worse than what you think. I would be surprised when you quoted the USA idea. I got scared. I said, well, are we being taped? Well, anyway, it's known anyway. So here what I don't understand is, I wonder these contradictions, because, well, they bomb first and then you come as the good doctor, right? I'm not putting down what you're doing as a clinician, but as a model NGO, countries that have been successful, I don't know, Costa Rica, Cuba, who had a doctor who preferred to take arms. I'm not advocating that, but it's a political solution, right? In desperate situations. Scandinavia, Kerala, the first years of Sri Lanka, it's the people taking control and having a strong public health system rather than NGOs and good doctors. Because the image that you project, you yourself acknowledged when you said, am I a guru? Is that of a morally superior doctor. And it's not about individual morality. It's about social institutions. It's not about being better and having more compassion than the next. It's about people having economic democracy. And you sell an image that it's all about individual goodness which could be very humiliating, actually, for somebody in a poor country, because...
I'm not sure you have read my books.
No, no,
Pathologies
that's right.
of Power. Let me just say, I'm not entirely sure I understood the question, but I will
The question
make
is how you deal with these contradictions.
Well, I'm not sure exactly which contradictions you're talking about, but I will say this. On a
Working
couple
with
of,
Bill Clinton, for example.
well, I mean, again, I was actually, never met him until after he was not president, just as an aside.
Well, of course.
Now, but let me just
it's
say...
a different person. Everybody is different, but...
Well, I am an American, if that's what you're saying. We got a very unpleasant foreign policy history. I would like to correct a couple of things, though, just the errors that they're historical errors. Actually, the overthrow of Aristide was in 1991. That was before Clinton was president.
Right.
That was a Bush administration. And the second time was in 2003. It was a slow motion coup, 2003 and 4, again, afterwards. I think that's...
Yes, but during his administration, he didn't push for a change in the in Haiti.
Well, that's not true. I didn't work in his
true.
administration, but I disagree, and I wrote a book about this called The Uses of Haiti, which you may have missed, even though it was translated into Spanish.
No, as I said, I'm not Spanish, I'm Catalan.
Oh, sorry. Yeah, sorry. It was, it was translated in Barcelona,
Okay,
but into the wrong language, clearly, Catalan. Spanish, I mean. But, so those are not, that's not what the history is. It was 1991, 2004, and actually, the Clinton administration was supportive of democracy in Haiti. And, you know, again, the big problem there was their trade policies, right? Post-NAFTA neoliberal trade policies. That's the way that we mostly undermined sovereign social justice governments, was indirectly, not through direct foreign policies. And you know, I think those are bad policies, whether they come from Europe or the United States or Canada, for that matter. And I would think we should marshal our efforts against them. On the question of building compassionate systems to deliver care by empowering sovereign nations to do so. That's clearly what I'm advocating here, right? And not the QPE, the quest for personal efficacy, the idea that we care more about, let's say, someone in Haiti or Rwanda than a Haitian clinician or community activist who's Haitian or Rwandan. Again, that's what I meant by structural compassion and structural social justice, that we need to make sure that we're involved in change that will allow other people to become agencies of the attack on structural violence that's bothering them, that's afflicting them. And you know, that's how I've always felt about this work.
Well, one thing is what you say or what you write, that the other thing is the image that you project and how they write about you. I remember The Good Doctor, that was in the New Yorker, for example. So you may have a different personal agenda, but as you saw, the way people see you it corresponds more to the way I describe it, right?
Well, I don't know. I actually haven't done a survey of how people see me, and that was an article written by someone else 14 years ago. But if you don't like it, then I hope you like the stuff that I wrote. And, you know, I'll keep writing about health and social justice in the hopes that I hit something you do care for.
I'm sorry to interject, but we have a few people, and unfortunately, they will kick us out of this room at some point. I apologize for the interruption. Perhaps this conversation can be carried on. I think we're on this microphone, and thank you.
Hi, my name is Melissa. I'm a graduate of Global Health Masters that I completed 3 years ago, in which you, Dr. Paul Farmer, was my inspiration to pursue that. And let me just say that I co-authored a proposal, a nonprofit proposal to address water accessibility issues in Mangalore, India, using the concept of community health workers from your inspiration again, which ended up on the desk of the government of Mangalore. So it's an immense honor to be in the same room as you, a hero of mine. And my question is, for actually all of you, how do you deal with political red tape and political unrest and not be discouraged in your mission and your vision in your pursuits?
Well, I mean, I don't think that I can answer how you cannot be discouraged. Sometimes you are discouraged. I mean, I've seen some very brutal processes and events. You know, they lead to discouragement. I've seen, you know, as a physician, you also, or a nurse, you know, any frontline provider, you see lots of failures. But discouragement is leavened, of course, when you work with teams. You know, I pointed to my colleague, Dr. Israel. You know, you work with lots and lots of people, and that helps. Red tape, you know, again, this is something that requires a constant, repeated attack with a goal in mind. If the goal is global health equity, and you're trying to work through by strengthening local systems or public health systems, you're signing up. I mean, this is back to the NGO versus public sector argument. Only governments confer rights, right? So to bypass them completely is, you know, is a difficult, I think, a bad option, and that means you're signing up for some significant amount of what you're calling red tape. You know, in each of the places where we work, I mean, we work in Siberian prisons. You know, you'd think there'd be tons of red tape there, but there's actually a lot of people that we've worked with who are really anxious to improve the healthcare provision given to prisoners. So I think it is possible to exaggerate it. One of the things I've seen in Haiti is a lot of times when something gets stuck in customs because the missionaries or whoever is trying to bring something in hasn't really followed the rules, and it gets slowed down. So one way to avoid red tape is not to mess up. But again, I don't want to, just trying to give some counter examples. But all that said, neither of those two things is discouragement, which, you know, ought to go with some of the disappointments that you see in this kind of work, and bureaucratic demands that border on folly. You know, they're still nowhere near as bad as not doing this work, right? It's still very rewarding work. You see a lot of return. So don't be too discouraged.
Thank you.
Good luck in your work.
Hi, I'm Faisal Haji. I'm working on a dissertation in medical education and also a residency in surgery. The question I have actually returns a bit to some of the comments that you made to one of the earlier questions, and in relation to the NGOs and working with governments and when there's multiple actors in a given area or region. And it's a bit broader because I wanted to know your personal approach as well as the approach that PIH and even all the speakers, the agencies that you work with. How do you think about the negative consequences of the actions that you take, and how do you build that into your strategies when you're approaching something to be reflexive about the potential negative impact that you could have with all the good intentions that you do?
Yeah, that's a great question. Thank you. You know, I think the more time that you can take to step back and say just that question, what are the potential negative or unintended consequences of this intervention, the better, right? I do think, though, it is possible. One of the things I've seen in over the years, especially teaching, is, and that's true wherever you teach. I'm not talking about teaching in Harvard only, teaching in Haiti, is a kind of paralysis that happens when almost too much consideration is given to negative consequences. And then something that happens that is very disturbing to me is when, for example, just going back to the AIDS activism, one of the dominant trends in commentary was really that there may be negative consequences to rolling out antiretroviral therapy. And you know, you have to stop and say, okay, that could be true, but the main consequence is going to stop people from dying, right? Yes, there will be. One of the big ones was, well, what about drug-resistant infections? Like, well, yeah, that happens every time you use antibiotics, right? So I do think this imperative to action to avert suffering and to promote social justice, which is, you know, thinking about these crazy disparities that we face. I think that it's okay for that to be the dominant force, and that really, again, working in teams and trying to step back and say, well, what are some of the things what would, just having that kind of be on a checklist, what would be some of the negative consequences. That's what we do a lot in our work, you know, and when I think about the big challenges we face of unknown, negative consequences was always fairly far down the list, you know, working in, let's say, prison in Siberia, or going to Rwanda, Malawi, and Lesotho. The biggest consequences were challenges for mobilizing resources to get the job done right, and not some unexpected, you know, result. The results were mostly as expected, decreasing mortality, et cetera. And you know, that doesn't excuse us from trying to stop and reflect. Another thing is to think, and for me, I have to write about stuff to think about it clearly. I'm just not as fluent analytically as some people seem to be. And so I stop and think about it and teach, you know. I'll just give one little tiny example. Don't be scared. You know, healthcare financing is the biggest problem that we see in our work anywhere. How do you finance decent healthcare for people who are not using a market, you know, not paying for it out of pocket, which some people call the oops approach, out of pocket. You know, oops, no planning, no central healthcare financing, no public healthcare financing. One of the things I'm looking forward to doing is I'm teaching a course with the March of Sin next fall on health and social justice. Because I figure I'll learn a lot by stepping back from the everyday, you know, trying to build, you know, get a health system up and running, or working with colleagues to do so, and learn something from critical reflection on experiences elsewhere that I won't be working. But
Thanks.
Are you a surgeon? Is that what you say? You know,
Training to be.
Pretty cool.
Well, I'm glad you're thinking about this, and I'm working with a lot of surgeons who are doing the same, by the way, if you'd like to connect with them.
Sure.
And I hear there's a great surgery book with a great preface coming out, so stay tuned.
Hi, my name is Tatiana, and I'm an undergraduate student at McGill. And I was just wondering your opinion on voluntourism and organizations that send a group of untrained individuals into developing countries and ask them to work on projects such as mobile medical clinics for around 2 weeks and then send them out.
Well, I mean, I'm not a big fan. I think it depends a little bit. If you have a surgical resident, you know, that is someone who's trained, who's going for a short-term medical mission, it's very different from sending a primary care doctor, or, you know what I mean? Because you really, so I'm not in a reactionary way saying that's always a bad idea. After all, sometimes young people who are not trained, if they do no harm, do become engaged in a lifelong and much more serious manner because of these initial and very ill-conceived efforts. In fact, that's exactly what happened to me 31 years ago. As I went down, not on a short-term medical mission, but on a stupid one, my own, right? I spent the better part of a year there, and I know, I'm embarrassed to tell you, when I left that first year, I just said, you know, this was great, we did a great job. Well, it wasn't great, and we didn't do a great job, and it took me a lot of years to fess up, right, internally in my own, it's just, you know, silly. So that's a long-term dumb medical mission, but it got converted into a lifelong, you know, obsession with health and social justice. So I wouldn't want to be too tough either, you know, or too dismissive, because sometimes the unexpected consequences of purposive social action, back to my surgical pal there, wherever he went, did he leave already? Are that, you know, you get sort of trapped into decency over time. Sort that one out. So don't be too tough on yourselves or others. It's not the way to go, but, you know, sometimes, you know. Thank you.
Somebody please tweet "trapped into decency." I need to remember that one.
Even worse, entrapped, I think.
My name's Jane Pritchard. I'm a family physician. I work with various marginalized groups. But my question has to do with climate change as a health hazard. And I guess it's a question for all three of you. And so I'm thinking mostly of Canada and perhaps of the US, and trying not to be partisan, but we have this huge problem of climate change, and it will affect, of course, people beyond our borders disproportionately, but within our borders it will affect the poor more. And so how can we as physicians be involved in the delivery of the message that might, that will impact all of our patients and generations to come in a way that might change government policy around the use of energy? That's my question.
Fortunately, we got the pro here.
Yeah.
Yeah, well, I don't have a magic bullet answer, but I can tell you that healthcare workers have a voice that is absolutely priceless. And to be able to articulate that climate change is actually a health issue is huge. That voice still has yet to be heard. It is being articulated in some fronts. Even the Mayor's Committee on Climate Change and Adaptability is beginning to understand some of these. WHO's generating some of the figures on the number of lives lost already because of the climate variability aspect of climate change, but it's still at a relatively low level.
What's needed to bring it to a higher level?
Well, some of it relates to identifying and getting to the root of what the big climate change obstacles are. Back in 1985, at the worst of the Cold War, a small band of physicians got together, formed the International Physicians for the Prevention of Nuclear War, and said, this whole discussion about how the military is planning for a medical response to nuclear warfare is an absurdity. There is no medical response to nuclear warfare. And even showing how absurd that was by laying out that scenario was an eye-opener for people who were just trusting that, in fact, this is a road in which we had to go down mutually assured destruction in order to survive as a society. It was not a mistake that physicians were an integral part of that conversation and made a difference. Climate change is a slow-moving nuclear annihilation disaster. It just is. And if you look at the projections of heat, warming, climate variability, crop destruction, salination of water, air pollution change, not even to mention the fact that in Andhra Pradesh last week it was 117 degrees for a full week, and people were dying in droves as just the tip of the iceberg. Those are incontrovertible, kind of facts that are leading edge of what climate change has in store for us. And it's inherent that we need to be part of that conversation. It happens, we have a reporter from the Toronto Star who's here today because he's interested in hearing how physicians can make such a radical impact on things like what's happening in AIDS deaths in resource-poor countries. The climate change story is a harder story to tell, but it's still a story that has to be told and can be told. And it's not going to be just the academics, it's going to be the frontline physicians as well.
Thank you.
So we'll take those last two questions and then we'll wrap up for the evening. Go ahead.
My name is Omar Chaudhary. I'm an undergraduate student at McGill and a PIHer. My question deals with the recent trend that I've seen now on campus where there seem to be a lot of different global health organizations on campus that are promoting their causes that may or may not align with our own values. My question is, how can we collaborate and partner with these organizations on campus without compromising our own values?
That's a great question. Do we take them both? Well, I'm just going to say, I think I've been struck by the values around health and social justice that PIH is embracing are linked also to lots of fairly technical interventions, right? Like, what does it mean to do health system strengthening? What does it mean to worry about coordination with other partners in order to strengthen health NGOs? What does it mean to think about how to procure medications and improved diagnostics. So those technical things that someone working with PIH would be really passionate about, some part of that, are not, not everybody. It's kind of like the question about short-term medical missions. I don't know how you thought I did on answering the question, but you could say, okay, well, that's not really consonant with our values, which are, and I hate using the E word, empowerment, but which are trying to build systems so people can, not depend on the mercy of strangers, right? But I think there's enough overlap just with anybody who, gets involved in something for all kinds of reasons. I don't love describing my first year in Haiti as kind of goofy. That's a long time, right, to be goofy. And yet, when we say it's not consonant with our values, I still think we can find ways of connecting with those groups. I know we can, And then, I'd like to hope that the reasons that you're choosing to support Partners in Health will be compelling to other people. I will say this, I don't think we can, not grow the student solidarity groups. And we need that to really grow. If you say grow a movement, what does that mean? Is it just, again, kind of to be goofy? Or do we say this is how we'll power this forward so that the kind of disparities that any of us could see, that you can still see, are going to be a thing in the past? So I would just beg you, as your comrade and coworker, to try hard to do that, because there's just a lot of, passion and smarts out there that we need on the case. Plus, you can be on many cases at once. Keep at it. Thank you.
Thank you.
Dr. Cherniak.
Hi. So my name is Bill Cherniak. I'm almost done a family medicine residency here in Toronto. And I'm working
And was on call last night.
And was on call in the ICU last night, yeah. At that great hospital you've heard of at St. Mike's. And I'm working with a bunch of great people, healthcare professionals, to run an organization that does work in southwestern Uganda. And some of them are here in the room tonight. And I just found the question, I've sort of willed onto stage by the question about short-term medical missions. And I've sort of gotten into, I have, I guess, a comment and then a question afterwards. A lot of discussions about the utility of short-term medical brigades and whether or not they're beneficial. And I just wonder, from everybody's perspective on stage, looking at the different organizations and whether or not they necessarily kind of come in and what might be kind of a parachute model where they come in onto the ground, come in for 2 weeks, spend a bunch of time in the hot sun, then leave, versus whether or not they work with a partnered model where they actually are helping a particular niche in the community and then have long-term goals and directives. And I would just sort of say that there's a difference between those parachute models versus the models where you actually serve a critical role, even though you're only there for a short period of time, and you can evaluate those organizations before deciding to work with them, before writing off the other short-term brigades. And actually, you made a great point about a number of different utilities of it, of getting people involved in global health and those sorts of reasons. And I'd love to hear all of your perspectives on that. And then my other question was with respect to comments before about government agencies and basically the need for NGOs to work within a government regulatory framework. And working in Uganda myself, I guess the question is, what about when those governments fail, and when, how do you sort of balance the benefits of working within a government framework where they have so much access to resources and basically coordinating large groups of people, versus where you're sort of concerned that you might get yourself drawn into something you don't want to be in those relationships, and your thoughts on that. Oh, and also there's a Graduate Student Alliance for Global Health at U of T, to that last question. And so it combines all the different interdisciplinary aspects of the university, and you can find lots of groups there.
I'd like to talk a little bit about how we've tried to handle this in family medicine, particularly with regards to our global health program. So for example, with our work in Ethiopia, we have considered to be if we do have family medicine residents coming over, which we do at times, we really think it's our responsibility to orient the residents, to host them, to make sure they're okay. Our big concern is always, are we getting in the way of our Ethiopian colleagues of doing their everyday business? So it's really helped for us to have a sustained presence in Addis Ababa and to right now have faculty who are there full time, right? You know, we've got individuals who are now in their second year there. And for us to sort of take that responsibility. I also did a goofy thing in Tanzania, and it was kind of a parachuting thing that I did, and it caused me to become profoundly inspired. But as soon as I met Catherine and really grew to understand the right way of doing these things, I realized how wrong that was. But so it's kind of affected how I feel as Catherine brings to me, you know, Lynn, I think we need to develop a bit of a policy here around, we're not having our residents go for 2 weeks for, say, some of their global health experience, et cetera. And we've had people really mad at us around some of these things, around our unwillingness to approve really, really short experiences, et cetera. But yeah, I think it's really important for us not to create a burden for the hosts that we're working with.
You know, I got a chance to talk about that already, and I hope I struck the right tone. Right? It's not the way to go. That said, I know it's late, and I won't take this up, but I'd be glad to talk to you about the many instances in which short-term, you know, what do we call them, medical brigades or trips, can have a very positive purpose because they're fitting into this delivery platform, right, you know, that is really tended over time, obviously years, and also allows for local capacity building. You know, well, I can tell you what we did, and also it wasn't very popular, was we realized many years ago in Haiti that it would be very difficult to document any positive outcome for a lot of these trips, and so we try to move it towards surgical trips. You know, because there you can imagine how you line up patients who need elective surgery, right? I could go through a list. Don't worry, I won't. And then you know that after the surgical teams, because they're not just surgeons, leave, that these patients have follow-up care, et cetera. There are lots of examples, right? It's just that if we want to, promote the QPE, quest for personal efficacy of young people, then probably those short-term medical brigades are not the best way to do it. I acknowledge that it's difficult to do, and the unintended consequences or the intended consequences of that can be really lifelong commitment or openness to realizing that what you did in Tanzania was goofy. You know, that's a big thing as well, to understand what you did that wasn't really very good. So.
You know, because there's public health students here too, I think it's worth saying that there's public health versions of medical tourism, if you will, and the same issues apply, perhaps a little bit differently. Oftentimes, public health tourism will involve multiple trips to be able to grasp the population angles of the things that are being studied. But I guess my more universal truth in managing some of these experiences over years is that your partners, if you've built really good, trusting relationships on the ground, will tell you what's working and not what's not working. They may not tell you in exact, direct words, but if you have a good relationship with them, they'll be able to help tell you whether it's actually positive or it's a burden. And that's part of the discourse and part of the interchange, and also having bidirectionality to it and making sure their trainees can come to your institution is an essential part of creating balance and making it an overall positive experience.
Well, thank you, everybody. I feel honored that I got to have a response from all three of the panelists. So thank you.
No, thank you. Thank you.
Thank you.
I'm going to advocate for the lady with the striped dress to be able to come to you individually after the talk, because I'm afraid we'll see an exodus, and I do want to thank everybody in the room, and to you, Paul, and to our friends and partners in health, again, a very special thanks. You might have noticed that we so wanted you to feel at home, that we went out of our way to set up various construction sites in streets throughout Toronto to block the traffic and make you feel like you were back in the middle of the big dig. And two things are true about the next time you visit us. The traffic will likely still be there, but so will we. And our willingness to continue this conversation and work with PIH will be ever so strong. And so thank you again, and until the next time, à la prochaine. Merci.